Hello everyone, thanks so much for signing in for the last of our sessions in the trauma module, and we're very lucky today to be able to have Felice D'arco, who is an absolutely brilliant consultant paediatric and adult neuroradiologist who works at Great Ormond Street and also at Guy's and Tommy's and the Evelina London Children's Hospitals with me. And he's going to be talking today about non-accidental injury, and he's going to focus mainly on some of the controversies that are present in the scientific literature related to the radiological diagnosis of abusive head trauma and how you can approach the complexity of these scientific evidences that are present. This may seem like a sort of high-end lecture, and remember that these sessions are focused at the higher level neuroradiology trainees, although everybody is welcome. But even if you're in your earlier years of training, you'll find a lot of what Felice is going to say useful. And remember that your reports are ultimately legal documents, so you'll want to know how to be putting exactly what you need to in your reports. So thanks so much to Felice, and over to you.
Thank you very much. First of all, thank you, the British Society of Neuroradiology, for the invitation, and thank you, Lal, for this invitation. I'm really happy. And as Lalani said, this lecture will be not about the science of, only about the science of non-accidental injury, radiological signs in children, because the radiological signs are easy to see. The problem is the interpretation of these signs. Sorry, I have a chat. I don't know. Yeah, okay. So how to interpret these signs and how to interpret the literature, because really the problem is to do not overcall or undercall a possible non-accidental injury. The problem is when we are dealing with, for instance, skull fracture. And in regard to skull fracture, I will show you the literature is not so strong as for the so-called shaken baby. How we approach and how we understand where the knowledge, the ultimate knowledge we use for our report comes from. So this will be the main teaching point. So call the things with the right name. I will show you some radiological findings. I will show you some mimics, and I will show you the right protocol, which is very, very important. So it's very really important that you do the right scan in the right moment. And I will speak extensively about the controversies, in particularly the so-called SBU reports, and the responses to the SBU report, and all this discussion that is still going on, not only in the scientific community, but also on Twitter, for instance. And you need to be aware of the strengths and weakness of these papers. And then I will speak about fractures. So let's start with this case that was given to me by Dr. Kling Chong. And this is a case of a 5-month-old male after a minor trauma. He had normal trauma that a child can have, for a small sofa, for instance. There was this increase of head circumference reported with normal neurology. And as you can see here, there is excessive CSF spaces surrounding the frontal lobes. Now, this is a very common finding, and these are the possibilities. This is really easy to answer. Can it be hydrocephalus? So we page the neurosurgeon. We know that there is sometimes external, so-called external hydrocephalus. I would not use in any of my reports so-called non-obstructive hydrocephalus, because all the hydrocephalus are obstructive, but this is all another big topic. Or there is a brain malformation, i.e. it's not that there is an increase in size of the CSF space, but a small frontal lobe, maybe because these are polymicrogyric frontal lobes. Or this is totally normal and there is nothing we should do. Or because of the appearance of the white matter, here quite hypodense, this is diffuse cerebral ischemia. Think a bit about that, but I'm sure that most of you know that this is completely normal. And why is that? Because in the first year and a half of life, there is a discrepancy in the speed of growth of the skull in comparison to the brain, and you can have this kind of enlargement in the frontal lobe that normally when the child will be older, this is the same child, 19 months old, this is an old scan, normally we don't scan this likely now. So when the child starts walking and there's a development of the venous system is more developed, basically you have that the brain catches up. If you read the literature, and this is, so we call this benign enlargement of the subarachnoid spaces, or we don't call it at all and just say that this is normal. Now, if you look at the literature, there are a lot of different terms like external hydrocephalus of infancy, benign communicating hydrocephalus, pseudohydrocephalus, and all of these terms, hygromas, that can lead to confusion. And I show you this case for two reasons. First, to show you how the approach to literature is very important, and second, to show you the difference between this appearance and pathological appearances that we can see in the pericerebral spaces in case of abusive head trauma. These are best on MR, and you can see that the hallmark, radiological hallmark of the subarachnoid spaces are the presence of bridging veins. If there are all these veins coursing into these pericerebral spaces, we are sure that this is subarachnoid compartment and this is normal. What about this CT? Look at the sides of the pericerebral spaces, pericerebral spaces along the frontal and temporal regions is similar to the previous, but the density is slightly different. And most importantly, this child was not normal neurologically. If you look at the density of the ventricle and the density of most of these spaces, the ventricle are more hypodense. And if we zoom here, we see that basically there is an extra space. So this is our subarachnoid space, similar density to this fluid along the falx, but this is something different. This is subdural space, is a virtual space, should not be there. And if we do an MR, so it's very important in the approach of non-accidental injury and abusive trauma to consider both CT and MR. But if we do an MR, there is a really big difference because here there are, in the subdural space, there are no vessel, no bridging veins. So these are subdural space. This is profoundly abnormal pattern and is completely different from the previous one and from the best, although the appearances in CT can be sometimes similar. However, this is not normal, and we were let's say lucky as radiologists because we go cranially and we see hyperdense blood, so we are sure that this is blood, and also hypodensity of part of the brain that is in keeping with a brain damage. So this was a non-accidental injury. Actually, the correct term is abusive head trauma. The first thing that you need to consider is that in this case, so there are two things very important in your report, and I'm telling you that because we see a lot of reports from external emergency radiologists, and they still do some mistakes in the way they describe the findings. The first thing is that mixed density doesn't mean that there were more than there was more than one event. So you never use acute on chronic, even in this case when you see hyperdense blood and hypodense fluid here. So you never date, not even in CT, and I will come back to that, showing the relevant literature that you can use in your report, and you should really use relevant papers to give a bit of strength to your report. So first teaching point for you is mixed density of subdural doesn't mean different insult. And why is that? because first of all, the density of the blood encompasses quite large ranges of days, even if it's hyperdense, and I will come back to that later, but also because there is flushing from the fluid, the CSF normally present in the pericerebral extraaxial spaces, which mix the blood physiologically. And if you cannot date in CT, even less you can date on MR. And the second thing is that when you have a suspected non-accidental injury, abusive trauma on a CT, you need to do an MR, and you need to do an MR with the right protocol. What is the right protocol? Two things that we learned from the recent literature, the last 5 years, is that we need the brain, but we need the brain with gradient sequences, in particularly SWI is better than the gradient, that can allow us to pick up a very subtle blood collection, but also to see the presence of blood in the eye, so to see, to suspect, waiting for ophthalmological confirmation, the presence of retinal hemorrhage. But also you need the spine. And when you do the spine MRI, you need to do the spine with fat-saturated steer or spear sequences, because again, we learned from recent literature that the ligamentous injury is quite consistent finding in non-accidental injury and abusive trauma. Although again, there are some controversies related to that, because it's very difficult to distinguish this ligamentous injury from fluid accumulating in a patient that is just lying down in ICU. So everything you you can write things looking at the literature, but you need to understand that these are papers made with limited number of patients, and sometimes there is no kind of control group and so on. So it's very, very difficult, and this is why you need to understand the papers in depth. But you need to remember at least to do the right protocol, which is CT as a starting point, and then MR with the SWI or gradient sequences, and spine with steer sequences. And the best paper you should have to support your diagnosis of abusive trauma is the consensus statement of abusive trauma. The main point of this very strong manuscript is that you need to have the whole picture. You cannot diagnose abusive trauma only based on neuroimaging or only based on X-ray. You need to have the general context, and of course, as we all know, the combination between subdural hematoma, retinal hemorrhages, in particular multi-layer retinal hemorrhages with specific characteristics that I will mention later on, and encephalopathy. So for a neuroradiologist, encephalopathy, the radiological surrogate of encephalopathy is an MRI showing brain damage. This combination is suggestive of abusive trauma, but in absence of suitable alternative explanation. And my personal suggestion to you is to use at the end of your report something along this line, because I will show you some example when complex trauma that can be domestic trauma, accidental domestic trauma, can create some very difficult radiological pattern in terms of interpretation. So remember to consider if there is an alternative explanation. Now I have to show you a video which is from YouTube, and basically this is the theory. Because the skull is more or less fixed and the brain is moving, the movement of the brain creates some damage and bleeding of the bridging vein and superficial brain of the superficial veins of the brain, accounting for the subdural hemorrhages. And this also explains why there is a reported high frequency of vein thrombosis. And this is important as to consider that vein thrombosis can be the consequence, not the cause, of subdural bleeding in a context that is suggestive of abusive head trauma. Of course, this shaking, this is the theory, will create some damage also within the brain with some problem in the center that control breathing, and this would explain the presence of diffuse hypoxia in the most serious cases. So that's the theory, and that's a nice 3D video showing this this abnormality. And this is the OPS animation is the group of people that created this video. So what you need to know about the consensus paper, that abusive head trauma is the best term to describe the abnormalities that we see in these children. Why? Because this is not a shaking alone mechanism. Most of the time there is also an impact involved, so the shaken baby terms is not all inclusive, and we know now that abusive head trauma can be caused by shaking alone, shaking with impact, or blunt impact alone, and blunt impact alone is basically a problem because normally we have in these children fracture, and the analysis of a fracture and the original fracture is more difficult. But this is the first thing you need to remember from the consensus paper. And they say this, they say this very strong statement. They come out with strong statement that abusive trauma is non-controversial medical diagnosis, broadly recognized and managed throughout the world. Lack history, changing history is important, so remember the context. And it's very, very rare to have only isolated brain intracranial injury. So look at the retinal hemorrhages, fracture, and other signs of child abuse, the family, and so on. The bottom line is that you need to speak with your clinician, you need to speak with the social service, you need to have all the information possible. And if when you do the multidisciplinarity meeting, your understanding of the neuroradiological findings change, you need to put an addendum. So do not be stuck or defensive in your conclusion. Remember to exclude mimics. Now, what happened a couple of years ago is that the SBU report came out. What is the SBU report? SBU report is a review of the literature, and they say, we want to review the literature related to the triad, subdural hematoma, retinal hemorrhage, and encephalopathy, and to see how many papers are good, how many papers have low study quality, and how strong is the triad in predicting abusive head trauma. And they came out with very few papers, only 2 with moderate study quality, 0 article with high study quality, and 28 articles of low study quality. So you read the conclusion, and they say that there is insufficient scientific evidence on which to assess the diagnostic accuracy of triad in identifying traumatic shaking, and limits scientific evidence that the triad can be associated with traumatic shaking. That's a big problem, because I'm telling you, they are using this in tribunal. The lawyers and barrister will ask you about this. I was in tribunal, and one of my colleagues, a neurosurgeon, was asked about this case, this paper, which is a review. The conclusions are very, very strong. The systematic review is a strong kind of paper, but you need to, again, read the literature in depth and understand what are the flaws of this paper, to use them and to really do the right thing when reporting. That sometimes is to not overcall an abuse, because both ways you can have consequences for family and children and society ultimately. There were a lot of response, but if you need to choose one, I will suggest this one from the Royal College of Pediatrics and Child Health, because they really show point by point all the problems in the methodology when of the SBU report. And I will show you, just I summarized the most important thing, but before, remember that this is something of social importance. It's not as some of you know, I have this love for inner ear malformation and genetic correlation. That's quite niche, but abuse, child abuse, is something that is all over the news. Whatever we write has a big impact for family and children and society and our colleagues. So we need to know our stuff, and this is why I did this lecture in this way. So main criticism to the SBU report from the RCPCH. First of all, they create this isolated traumatic shaking, which is a non-clinical entity. So if you create a novel entity and you want to explore something, basically you are setting a wrong question. So the premises for that review were based on an entity that is made up, because a child abuse is something more complex than someone just shaking a baby and then put it down. First of all. Second, they misquoted a lot of references. This is one example, but there are other misquoted references when it comes to retinal hemorrhage that are very powerful, specific retinal hemorrhages, a very powerful tool to support your suspected non-accidental injury diagnosis on neuroimages. And they never explain what is triad and what is encephalopathy. So the methods are not well defined, and there is a search term bias. For instance, they look for brain edema on images, while the triad, the so-called triad, is characterized by the encephalopathy, which is a clinical entity. And the gold standard is unrealistic because they consider only admitted or witnessed traumatic shaking. And that's a really big problem, because it's as to say that in absence of admitted or witnessed traumatic shaking, there was no shaking at all. But if you reason along the same line, we will have that the jails will be empty, because only confessed homicides, for instance, will be charged. So the unrealistic standard is a very important problem in the SBU report. And this is just, these are just few examples on how you can say in a tribunal, and I said, I think almost 1 year ago in a tribunal, to a barrister and to the judge, say, listen, I heard the barrister quoting this paper, that's fine, the paper has been published, but you need to know that the Royal College of Pediatrician and Child Health asked for this paper to be withdrawn. So it is extremely important that you flag that not everything that is written in literature is just gospel because it's been published. So there were problems in the search strategy, as I told you, and also, interestingly, they say that they arbitrarily included in the search method only papers about the triad with 10 patients or more. But the case reports they use in the differential diagnosis for the triads are case reports. So there is a really biased approach to this review, and that's very important. But even if you look at the case reports the authors used as reference, speaking about mimics, so only 5. So I spent a lot of time because I went through all these cases, and there is a beautiful paper by my colleague Dr. Mankad, and the group from Toronto as well is involved, about mimics of abusive head trauma. But if you see here, we have immunological disease that can present with triad, but these are easily excluded. And then we have delta storage pool disease, very rare and very easily excluded abnormal genetic problems. K vitamin deficiency is immediately checked in this patient, vascular malformation on aneurysm, and hepatitis. Hepatitis, I want to show you this case because it's emblematic of what they've done, trying to wash away the importance of the triad in the abusive head trauma. This is the case: fetal spontaneous subdural bleeding due to neonatal giant cell. So again, go deep and deep and understand the literature. And what they had was this large unilateral subdural hematoma, creating brain shift and edema. So of course you have the edema, of course you have encephalopathy, of course you have a subdural extraaxial blood and retinal hemorrhage, but this is not the triad. The subdural abnormality we have in the shaken baby are multiple, scattered, and do not have any mass effect. So this is a false saying that this can be a mimic. It's a mimic only if you read the conclusion of the paper, but when you read the paper itself, this is not a mimic. And very important for a radiologist is to understand that there are different types of retinal hemorrhage. If you have retinal hemorrhage, there are multi-layers, numerous, extending to ora serrata, and associated with retinoschisis. They are extremely specific for child abuse. And this paper from this commentary from Professor Levin, who is a neuro-ophthalmologist, say to ignore this description is like saying that the rose is not different than any other flower. I like this phrase, so I highlighted it for you. And this kind of retinal hemorrhage has extremely high positive predictive value. And again, author misquoted some reference. And use adult literature he concludes saying that abusive trauma is a primary cause of the most common cause of retinal hemorrhage in young children beyond the neonatal period, and specific retinal findings makes the likelihood of abusive trauma dramatically high. So ask your ophthalmologist what kind of retinal hemorrhages are there. And then timing controversies, why you should not date. This is a paper that came out last year in AJNR, and as you can see here, even the acute, the so-called acute blood on CT, so hyperdense blood, can be hyperdense from 1 day till 2 weeks. So you really do not have elements, most of people think 10 days, but anyway, it doesn't matter. You do not have radiological, neuroradiological elements without the clinical context to date the blood. So bottom line, do not date, not even in CT. And look at in CT findings. So you can have hyper-intense mixed pattern or homogeneous or hypodense subdural in all the stage of development. So again, don't date, not even in CT. The only thing you can say, according to this review, is that in the moment you see the membranes, you can say that this is older than 10 days, but you can, because even in neuropathology, the first formation of membrane is described microscopically visible after 10 days. And these are the membranes. And what does it mean? That you have subdurals, they stay there for a bit and they become bigger, and they organize themselves in compartment with this formation of membrane. But this is just an example, not very useful, of course, in dating the moment of the damage. It's just to show you how you should not date. Of note, all this beautiful scheme of how the different hemoglobin changes over time was came out from adult literature and intraparenchymal hematoma. You cannot date using the intensity the subdurals. I hope this is clear. And finally, the fracture. First of all, if you can buy or ask a friend for this book, is amazing, and there is a chapter only on skull fracture. And as a general rule, but that's really controversial, guys, because you read again the literature, and I spend a lot of time going through all the papers. It's not really easy to do this differential. But if you have a non-accidental injury, so someone is pushing a child against a wall, or is hitting a child with something, of course, the forces involved are more. So you will have more multiple complex fracture, depressed with the fracture width that will be more than 3 millimeters and in different location, and also frequently combined with other fracture. Simple fracture will be more in keeping with accidental. trauma. But there are two things you need to remember. First, the most common fracture in children with accidental trauma or non-accidental trauma is a linear parietal fracture. So if you have a linear parietal fracture and something is not right in the history, you need to keep your differential open and an open mind first. Second, it's not true that a fall from a short high will not cause fracture. That sometimes can be complex. This is, I'm sorry, this is in German, but this is very interesting because it's an experiment that you cannot do anymore now for ethical reasons, but they take some deaf children, 2 months, and they make them fall from less than 1 meter, and as you can see, they all had a fracture, especially in the parietal bone, but sometimes bilateral, sometimes multiple fracture, even from a short high. So Weber studies show that it is possible to sustain a skull fracture in an uncomplicated fall from a high less than 1 meter. Of course, it's much more uncommon to have a bilateral complex fracture in a child that just fell from a sofa. But keep in mind that this high range of 1 meter is somehow arbitrary, and you need to discuss very carefully with your colleagues the origin of a skull fracture, whatever would be complex or linear. Look at this case. This is an accidental fall. This was witnessed by 2 doctors, and basically the child fell from a pram while descending the stairs. Normal neurology, so this is an impact, it's not a shaking, but you have 2 fractures of the parietal lobe with complex and stellate development, and you have contractile blood along the surface of the brain on the other side. These are not bilateral patchy subdural. This is very close to the surface of the brain, but that's not the point. If you look at the table I showed you here, he said you have a complex fracture combined with intracranial problems, you will have more likely to be non-accidental. But this was just a very complex accidental fall from the stairs. So again, keep your mind open, and sometimes you cannot solve it, and you can say, this is complex fracture, I'm not aware at the time of the report of a consistent explanation for that, please investigate. That's fine. But remember that when it comes to fracture, especially when you fall from the stairs or a child from a pram, the literature is scarce. And again, most frequent accidental and non-accidental fractures, linear, parietal, uncomplicated. In this case, we should also not dismiss immediately as an accident. Technical tips: ask your radiographer to do 3D reformats. We still do not see them, and we can do, but of course, if this scan is sent somewhere and they do not have DICOM viewer, it's a problem. So ask them to do that and to send to the PACS. And remember the variants, especially in the posterior fossa, we have basioccipital bone, exoccipital bone, and 2 parts of the squama occipitalis, supraoccipital bone derived from cartilage, and intraparietal bone derived from membrane. And between them, there is Mendozal suture, one of the so-called persistent suture that can simulate a trauma. So you need to know your anatomy, your developmental anatomy, to distinguish between fracture. In the posterior fossa, the Mendozal suture is very important, and also the midline occipital suture remnant that needs to be less than 2 centimeters. If it's something like that, because it's a weak point, and if you have a consistent fall on the back, and this is at least 3 centimeters, you will consider this as a fracture. And I will suggest you to read this very, very interesting paper on how to distinguish skull fracture versus accessory suture, sometimes very, very difficult. I hope it was clear so far. In conclusion, the triad should be still considered supportive of abusive head trauma. in the right context. You need to use a multidisciplinary approach and use the consensus paper. It's very important. It is a consensus statement from several societies, and you really can use to defend your report. But you need to use with, cum grano salis. You need to know what the different papers say about the topic. Controversies are present. We should not deny that. We need to be aware of the literature, and we need to use the right